Good morning, everyone. It really is a delight to be able to introduce this event and to introduce the keynote speaker, Sir Andrew Dillon. We've come a long way in the year and a half that the AHSNs have been in set-up and start-up. So this event probably is, the first major landmark along the route of the academic health science network in the Northeast and North Cumbria becoming visible, active, and effective. And the message from us and for us from NHS England is very clearly that we are expected to be active and delivering from now on. So I'm kind of torn here today because so many of you have heard the AHSN deal before. I really just wanted a show of hands. How many of you are not familiar with the AHSN, the Academic Health Science Network, as a system? There are a few, so we'll do some context and background. It's just a matter of how I spend the 10 minutes, basically. So we'll do a bit on context and we'll do a bit on what is expected of the HSNs from NHS England. We'll do a bit on our work programmes and our stakeholders, and then I will have the pleasure of introducing Sir Andrew. So the genealogy of the HSNs is a fairly straightforward one. We have Innovation, Health and Wealth report, which was a direct result of the requirement for the government to get together its plan for growth. And the NHS and various other public sector organisations are a major part of the economy and a major part of the innovation structure. And we have collectively to play a part in that economy in transforming the growth profile. So the innovation and adoption of best practice within the NHS is seen by the Treasury as a major part of what has to happen for the UK economy to get back on its feet again. The other part of innovation and adoption are the other bits of that are relevant today, are that innovation and adoption, the use of best practice transforms patient outcomes, as Paula said. We have the opportunity to simultaneously improve quality and productivity, and the driver for economic growth in terms of how the products and services that the NHS use and develop and their place in the world market are very clear. And that's why we have the interest from pharmaceutical and medtech companies in accessing the NHS as an open innovation platform, which is a major part of what we do as well. So the strategy for life sciences, which was published around the same time, set out a number of deliverables, and we've just had a comment on that from the ABPI and others, which really suggests that our midterm report is it's a fairly mixed bag. If you go from the Catalyst and Catapult initiatives that were set out in that strategy document, for which I think these bodies would give sort of A-, through the AHSNs and the NICE implementation collaboratives, which are slightly more mixed message in terms of how much they're delivering in terms of this agenda, through to some things like Specialist Commissioning Innovation Fund, which was ditched, and the procurement on which there's been relatively little progress. This is a fairly mixed message we're getting back on a major strand of the Treasury investment and expectation. So we're setting out on the AHSN deliverables with a very clear view that there's an awful lot to be done, and the expectation of us from Treasury is very high. So the remit that we have, improving health outcomes, there was a fair bit of dismantling went on in the healthcare system over the last few years, and we as the HSNs are expected to provide that system-wide integration now, and we're expected to lead on the adoption and dissemination of best practice at pace and at scale. We're supposed to create wealth. Today is not specifically about wealth creation, other than the fact that the innovations and the testing of best practice has a rollout effect within the global economy. The key thing today and the tone of this is our role in working with partner organisations. we have a responsibility to work with the healthcare providers and industry in the region and nationally, and we have a responsibility to work with the other 14 academic health science networks in England to make sure that best practice, the adoption and dissemination of that is not just a local thing, that the expertise and the learning of that is shared across the other 14 AHSNs as well. These are our work programs. Today we're concentrating on the improving health and standards and the knowledge and information ones. Those are the space in which within the AHSN project that this work happens. We also have patient and public involvement work program and innovation, industry and wealth creation one. The timeline, so from 2011 when this was, the HSNs were first mooted in the innovation, health and wealth, we have been involving stakeholders at every stage in this process, us feeding back and establishing what the principles are and what the guiding, the guiding principles of all of this is, touching base with people who actually, for whom this actually matters, has been something we do, and that's part of what today is. That's the main part of today, is establishing the tone and the fora in which the HSN will do its work. So we have this collaborative. We have we are likely to have further collaboratives on patient and public involvement. We're likely to have medicines optimization theme. These are ways that these are fora in which the way that we work should be paramount. And the tone of these discussions today, and the fact that everybody came here willingly and with a smile on their face, and with the ideas of the work that they wanted to bring, that's what the HSN is about, and that's the kind of the HSN we're trying to create. We've got a vast number of stakeholders. If you only look at the member organisations, these are the people who pay membership fees to the HSN. It's a very low membership fee, but it's a marker in the ground. That's just the trusts. That doesn't involve the companies that we meet on a regular basis. It doesn't involve the charities, local authorities, and people like that for whom so much of our agenda matters. We are a network. We're not trying to do stuff. We're trying to facilitate stuff. We do not want to capture the nice environment. We want to facilitate it. We don't want to capture PPI. We want to facilitate it because we with a relatively small budget at about 4 million this year. We can't. We can facilitate. We can't do it all. We're here to create wealth, and it is interesting in this sort of very brief summary of what we're supposed to do that one of the key partners in creating wealth is NICE, and that recognises the importance of the pharma and medtech agendas within the wealth creation environment. The NICE appraisals are part of that, a major part of that. So. In the 10 minutes that we have to describe a very complex environment, this shows where we are. It's quite a cluttered landscape. It's a cluttered landscape physically, economically, and just in terms of the narrative, it's still very complex. We're still refining as AHSNs exactly how we're going to operate and what we're going to do. The programs of work that we choose to take on will be crucial in this. We're establishing today and for the next 6 months the way that we're going to work, and I come from a part of the world, you can probably tell from my accent, where we can make a story out of anything, right? Even this challenges even me, but so we are refining this, right? But we have the goodwill, and we can tell that today of senior stakeholders and the goodwill of the system to make this happen. Well, one of the things that like I said, I'm only here to introduce Sir Andrew, really, and one of the things that is clear from NICE is that the longevity of the CEO is both the 1999, I believe, or thereabouts. I've forgotten. Yeah, that's a hell of a testament to the effectiveness and vision. The fact that NICE, since then have become, it's not understating it to say they're a global brand, right? That's clear. If you look, what happened to the other slide? Oh, hell's bells. The other slide was actually nicked from a presentation that Sir Andrew has left on the internet from 2002, and he sets out there are 2 slides that take what NICE wants to do in terms of best practice and evidence base. And there are 1 or 2 semi-ironic comments in there which are a great value about it's not a bad idea to use best practice and evidence in healthcare. Right. There is also a wonderful cartoon of Tony Blair. Some of you may remember him. He's a minor local MP at one stage, but he has got the 4 letters of NICE as you know, and he's doing the puppet master thing. And the risk is control. And the risk is political interference. As a new chief executive of an organisation working within the NHS environment, the quality of the vision that has sustained NICE, right, and the clarity of that, and sticking to some principles that absolutely have to happen and absolutely are fundamental, you know, that's the learning that I took from that. The funnies about political interference are much less funny when you deal with the system day in, day out, but they are lessons well learned. So I'm looking forward to this. I hope I haven't used any of the slides that you were going to use today, but it's my pleasure to introduce Sir Andrew Dillon, the Chief Executive of NICE.
And Seamus, thanks very much for the introduction. I should say it's an absolute pleasure for us to be able to co-sponsor this event. One of the things I've learned, perhaps the most important thing I've learned over the nearly 15 years I've been at NICE, is that you can be as good as you like at crafting perfectly presented guidance based on the evidence and delivering it in all sorts of interesting and intelligent ways into the system. But it doesn't change anything of itself. It has to be engineered into day-to-day practice by people like you and the people you work with in the health and social care system. So engaging with your networks and similar networks around the country is absolutely critical to NICE being able to add value to the decisions that are taken by organisations, by individual professionals, by individuals to help improve the quality of life that they're living. So it's a great opportunity, and Stephen Sterica, who's our local implementation consultant, who's here today, and I'm very grateful for the opportunity of taking part in this. It's also good to be here in the north of England. I live about a quarter of a mile away from the River Thames, and for various reasons I've been up in the north since Friday. So I've been watching the news as the sort of blue on the map. If you see the Environment Agency's, well, there's another organisation under pressure. I have great sympathy for their chief executive and chair. You see the blue sort of gradually coming downstream in the River Thames, and I need to get back actually because I co-own a little boat which is moored at Teddington Marina, which is just at the edge of the blue bit. And I phoned up the marina yesterday just to see whether or not things are okay. Oh, no problem, they said it's absolutely fine. I don't believe a word of it, actually. So I need to get back down because I see a commercial opportunity for using the boat a bit further upstream. Another thing I find a bit puzzling is, why is it they call in the Army and not the Navy? You've got flooding. Because you think the Navy's got boats and the Army's got sandbags. So maybe a joint effort would be useful. Yes, I have updated, Seamus, this presentation from 2002, just in case you were worried. So I'm not including any of those slides that you mentioned. Although I did, I've got to do another talk on Thursday. Down in London, and it's a conference about value-based pricing for pharmaceuticals. There's some people from the pharma industry here. You'd be interested in this presentation because it's our approach to how we're going to take into account burden of illness and wider societal benefits. So I've been working on that presentation and on this one, and I got an email over the weekend from the organizer of that conference saying, can you send the presentation? So I did, but I sent this one. And I got a sort of reply back, which the conference organizers here will recognize, which is, the subtext is, this person clearly has no idea what it is he's supposed to be talking about at our meeting, but how do I say that politely? And this is a long email gradually reintroducing the concept of value-based pricing. And there's obviously hope that they might get the right presentation. Anyway, this is definitely the presentation for today. I think. Maybe this is somebody else. Oh, there you go. There's Tony Blair. Yeah. This is it's a BMJ. Excuse me, it's a cartoon in the BMJ from about the mid-2000s, I think. So just about 5 or 6 years after NICE was established. And it's about the same time that Richard Smith, who was then the editor of the BMJ, who'd been quite hostile to NICE in its early years, it obviously became a convert, comparing NICE to Shakespeare and Newton and the Beatles and the Teletubbies, actually, as one of Britain's finest cultural exports. I'll keep going. So here you go. Right. So just a schematic, a quick reminder really of the array of stuff that NICE now produces. And I put it in there because what we've tried to do over the years is to accept briefs, a bit difficult to refuse them when they're offered, particularly when money comes with them, but to accept briefs which add to, in some way, coherently to the array of things that NICE is doing, always drawing on the strength that we gradually build up in our ability to take an evidence base, synthesize it with great people drawn from the communities who are going to receive the guidance, and then putting a useful front end on it. And you can see that the range of things that we do now stretches right across the health system, so our offer to health is pretty comprehensive. To public health too, since we merged with the Health Development Agency in 2005, and more recently social care, which is a really interesting development because it gives us the opportunities I'll show in a moment for us to be able to bring together elements of our guidance which connect and perhaps help social care and help better manage that interface, which has never been particularly well managed. The years that I've had experience of it, and indeed being in the years when I had operational responsibility in Southwest London for trying to organise it. And that coherence has worked pretty much. I think probably the only slightly discordant note is the staffing guidance that we've been asked to produce that came out of the Francis report into mid-staffs. But here again, at least there's a connection. It's what's the evidence base for approaching the creation of safe staffing establishments in an array of acute settings, and how do you convert that into a tool that the system can use consistently? So right across the board, a pretty comprehensive array of things, but perhaps just striking the note now, mentioning the point I'm going to finish on, which is that it's fine for NICE to produce all this, and as I say, simply producing it doesn't make the change. It needs you to use it and put it into practice, and we're very conscious that though we hope it's a useful tool, it's a good thing, nevertheless a real challenge for you to use the guidance that we're producing it and weave it into your practice, whatever it is, into your responsibility. So we do our best to try and support you with that. Some of the things I'm going to mention are an indication of how that happens. And Stephen Stericker himself, one of our vast field force of 7 implementation consultants across England, is an example of ways in which we try, with limited resources, to make it as easy as possible for people to use the guidance that we produce. I'm going to start with public health because although NICE is probably still best known for the stuff that we deliver for the NHS, and certainly in the public side, almost certainly for the sometimes controversial recommendations that we make about new pharmaceuticals, it's what we're doing in public health and through our clinical guidelines program, we hope in social care, which in the longer term will make the biggest difference and offer the richest resource for people who are interested in the things that we do. And our public health guidance ranges across everything you'd expect, the challenges that you're facing if you're in public health, if you're interested in public health, the sorts of things that you know on the ground, the things that you want to deal with. And what we've produced, together with what the Health Development Agency had already created pre-2005, represents a pretty extensive resource. But we're going further than just simply producing the guidance, putting that front end on the evidence base. We're trying to think of ways in which we can convert that into tools that enable the system to look locally, practically at how they can convert what we're recommending into practice and get a return. So we're producing a series of return on investment products from the public health program. This one just illustrates the one on alcohol. You can see there, the slides, I know text on some of these slides is quite small, for which I apologise, but you can begin to see, if you look at the bottom of the slide there, so not in the red box, just the burden, which if you're in public health, you'll be very familiar with, huge amounts of money for the NHS, £3.5 billion. The cost of alcohol-related crime, enormous sums of money, and lost productivity. So these are vast sums of money. And it doesn't take too much arithmetic to work out the sorts of things, the modest investments that we can make that begin to make a difference, which are presented in NICE guidance and converted into this tool, can start to pay back very quickly. So we're trying to appeal here to people who've got stewardship responsibility for resources in the system, as well as those who've got professional responsibility in practice in public health in the NHS and in local government. And that new responsibility for social care, as I mentioned, is giving us the chance to think about how we can bring together different components of the guidance that we've produced in the past and the things that we're going to be producing in social care. The first piece of guidance and associated quality standard that we produced from our social care programme touched on the mental well-being of older people in care homes. And you can just see at the top of the slide there, this slide, I can't do it here. I'm probably going to blind somebody if I try point it in that direction. But you can see the relationship between this quality standard, the 50th that we've produced overall in the total array of clinical, social care and public health quality standards, linking back to the one that we produced on dementia, which is targeted largely at practice in the NHS. So what we're doing is making sure that the things we're producing from our different programmes, where they're on related topics, link together and connect. And the people that are producing the latest piece of work, referring back to them to make sure that there's a real read across between social care and health, or between public health and what the NHS is responsible for delivering in clinical practice. And again, just returning to that point about the array of things that NICE produces, we're very conscious that we produced over the 15 years or so that we've been going, something nearly 1,000 pieces of guidance of one kind or another. Even if you take an individual disease or condition or aspect of practice in public health, for example, there's an enormous amount from a lot of different programs. And it's a bit of a labour of love now, go through the NICE website to bring it all together. If you're interested in diabetes, for example, you can find something from all of the programs, public health, social care, our technology appraisal program, medtech programs, interventional procedures, there's things in the QOF. So what we've done is to start bringing that together for you into a series of pathways. So arraying our guidance in a form that's familiar to you, indeed familiar to people who might be living with particular disease or conditions, who have got an approach to lifestyle which is touched on by some aspect of the guidance that we've produced. So you can see how it looks on the screen. Some of you, I imagine, I hope some of you will have looked at and used these pathways. So pretty simple, and with a click or two you can get to virtually any piece of guidance that NICE produces. So I think by the end of this calendar year, all the guidance that NICE has produced that can be assembled around the pathways that we've been producing, and that's going to be somewhere between 95 and 100% of the guidance that we've generated over the last 15 years, going to be available through these pathways. So a much easier way of finding your way to whatever it is that you're interested. Or if you want an overview of an area of practice and you're interested in what NICE has produced, then use the pathways where they're available as a means of getting to it, rather than sort of trying to navigate your way through the website and putting it together yourself. And the theme again of it's all great, but it's a massive challenge. It's all great, but if you're just thinking about health NHS practice, none of us turn up very conveniently to our GP with just a single problem. Most of us, I'm included, always try to pack at least a couple of things in, 2 or 3 things, only because I think that's an efficient way of using the GP's time, although it's pretty obvious that the GP doesn't always think that's the case. But the reality is we're complex. We're all of us sitting in this room a complex set of problems of one kind or another. Most of us look pretty healthy. At some point we won't be. As we get older, we're certainly not going to be. So NICE's approach to segmenting its guidance into diseases and conditions makes it easy for us, or individual drugs or interventions of other kinds, makes it easy for us because the evidence base gets presented in that way. We can put boundaries around the guidance, we can make it doable. But if you're a general practitioner, if you're a health professional in any aspect of practice, if you're planning services, it's never that simple, and we entirely understand that. So the pathways are one way in which we're trying to bring things together in a way that makes it easier to do a bit of planning. But we're also conscious that there may be things we could do to help those who've got responsibility for managing multi-morbidity, and sometimes very complex multi-morbidity. So watch out for that. That's being worked on by Mark Baker, who's responsible for our clinical practice program. So we do understand life is not as simple as the way it gets presented on the NICE website, and there are ways in which we can, without trying to predict, the 10,000 combinations of things that you might routinely see and try to produce guidance on them. If there are ways and things that we can produce which are useful in helping you to use NICE guidance in circumstances in which patients are presenting with a number of diseases or conditions, then we'd be interested in hearing about it. But in general, we try to do what we can to pre-wash the guidance, so we're thinking about what it's like to use it in practice. Quite a significant proportion of our resources is in the implementation team at NICE, which Stephen and the other consultants, field-based consultants, are part of. So both face-to-face working, which we'd like to do more of, partnership working, and this is an example of it, which we'd very much like to do more of. We also produce tools at a national level, and they're all available from our website. We thought particularly about the challenge in primary care of using NICE guidance, so we've worked with general practitioners and other primary care professionals to build a section of our website which produces an array of resources for people in primary care. So if that's where you are and you're interested in getting speedier access to stuff that we're producing that you think might help, it's worth a quick look. And it's kind of interesting, thinking back over the years, the big question is, well, so what impact have you had? It's a question we tried to start answering in the first couple of years that we were going, and it was sort of reasonably easy because we were only really producing drug appraisals and we could take a look at the before and after data. Sometimes you'd be able to see a very clear signal from NICE having an impact on utilization one way or another. With 1,000 pieces of guidance, it's impossible for us to track all that and pretend that we know in every individual case what's happening. And the other thing is that we're conscious that quite a lot of what we produce has got a slow burn in the system. It's not something that you put into... something like a drug, you could say, well, if you produce guidance saying, yes, you use it, you could expect the NHS to start buying it tomorrow, and in a couple of months you could look back. And actually, that's true in some cases. But for quite a lot of our guidance, you don't see that. It's over a much longer period of time. And I was quite interested in a recent tweet from NICE, actually, which, of course, I follow on Twitter. And it was this one, only about a week ago, so cancer patients diagnosed quicker thanks to NICE guidelines, and diagnosis times falling by an average of 5 days. So I tracked that through, and of course it relates to a clinical guideline we produced in the early days of NICE. This was originally produced in 2005, and it was intended to help those who've got responsibility for making decisions about treatment plans for patients with suspected cancer. And you won't be able to read the detail of this, and sadly, unfortunately, I can't see it at all in the way this is displayed. I need to put this onto some kind of whole screen display. But anyway, it's a piece of work which was being conducted by Bangor, Exeter, and partly White my Durham universities, looking at, as it says, 20,000 people over 40 in England who were diagnosed with one of 15 types of common cancers. And you can see a quote from the lead researcher, Richard Neal, Professor of Primary Care Medicine at Bangor, saying that the study shows a small but significant improvement overall in diagnosis times for many cancers between 2001-2 and 2007-8, and he's attributing that in part to a signal from NICE guidance. And it's great to see it because it's independent, it's not NICE trying to do that. It's clearly a careful study of good quality. We know that NICE isn't the only signal that you pay attention to or that matters in making decisions in clinical practice, that's obvious. But to be able to isolate some impact from a clinical guideline, which are very difficult to track in terms of their impacts, is really good. And there are lots of examples like this on the NICE website if you're interested. We ask, and if you've got examples of where in your own practice you've done a piece of research or you've introduced a change in practice in some way, we'd love to hear about it because our shared learning database is proving to be a rich resource for people who want to both publicise what they've done because they might think it's useful to other people and just want to share the achievements that they've made. So penultimate slide, just to state perhaps some of the obvious why we're here, why you're so important to us as an academic health science network and a community of people. We can work with you to help drive the uptake of NICE guidance. We can't do it on our own. We just have no ability to do it. We've got to work with you. So this network and networks like this around the country are critically important. The challenge of working out what represents good uptake is not easy to solve. There's no simple answer to that. People are struggling at a national and a local level to work out what constitutes the right level of uptake. We make our estimates and assumptions at NICE, but they're just that. So working with you to help us do better with your local experience about what constitutes the right level of uptake, how we benchmark so that people can look at what they're doing and judge themselves. It's the most important thing in terms of their compliance with the guidance would be fantastic. We think we're quite good at taking an evidence base and converting it into something useful, but we're not perfect. And if you can help us improve our methodologies and processes, fantastic. Working with companies, part of your remit to improve health and wealth is something we're interested in. We already make an offer to companies in the life sciences industry to come talk to us in the product development phase, quite disconnected from our appraisal of their products, to help them think through the clinical studies, the sort of endpoints that we're looking for. So if there are things that we can do like that in collaboration with you, it'd be fantastic. And anything else that you can think of that we can make a useful contribution for, we're up for. And finally, just a bit of an advert. If you can't get enough of NICE, like me, over 15 years, then do see if you can join us at our annual conference, which is coming up in May in Birmingham. It's about 1,500 people there. It's the least tribal of the conferences in health and social care. You meet all sorts of interesting people there and lots of stuff around things that are of interest to you. Otherwise, you wouldn't be here today. So again, thanks very much indeed for the opportunity of speaking today.
Thank you very much, Paula, and thank you to the organisers for inviting me and having, if you like, the foresight to see the importance of the patient and public role in this area. I think at the moment it's an underinvested area in terms of implementation, and as an underinvested area has considerable potential to contribute to the future of implementation of NICE guidance and evidence more generally. So, this is what I'm going to be talking about. I'm going to largely focus on the role of the patient, but I will, towards the end, also make some comments around the role of patients and the public, largely as a lead-in to this afternoon's workshop, which, again, shows the investment of AHSN in patient and public involvement to not only have a plenary around this, but also a workshop later on, which is fabulous. My starting point here is you can't actually implement guidelines without patient and public involvement, and for sure patients and the public by their behaviour will make sure that you may not be able to implement them, either by the choices they make between what might be alternative options and treatment, the concordance with any therapy. Let's not forget that about 50% of the medication we prescribe doesn't get used in the UK. And also their lifestyle choices, in particular thinking about public health guidance. So we ignore this component of implementation at our peril. So I want to say a little bit about the importance of patient preferences, shared decision-making, supported self-management, and how that aligns with guidelines and guidelines implementation. It's obviously a major plank of current health policy, and rightly so. But some people have raised the question as to whether there is a tension, even a conflict between the concept of shared decision-making on the one hand, involving patients in decisions about their treatment and care, and guidelines on the other. That guidelines are what you should do, and shared decision-making is about what people choose to do, and those two things may not be compatible. Now, my argument would be quite the converse of that actually we need to align these things absolutely centrally in order to make the best implementation processes that we can here, and to achieve the sorts of outcomes that guidance is set there to support. Let's just think and be clear about what we mean by shared decision-making. And I think this definition is very helpful in this context. An approach where clinicians and patients make decisions together using the best available evidence. So shared decision-making is a mechanism for supporting the implementation of evidence into clinical practice. Shared decision-making can be seen as part of a spectrum of decision-making. At one end, paternalistic, doctor knows best, patient does what they're told. At the other end, informed choice, which sees the clinician, the nurse, the doctor as the technician in the interaction, if you like, the provider of information on the risks, the benefits and consequences of treatments, and the patient makes their own decision. And in the middle, what's largely, I think, becoming the preferred model of delivery is that of shared decision-making, the recognition that in any interaction between clinicians and patients or the service and its public, there are two sets of expertise in that room. There's the expertise of the clinician who should have available to them, and we'll come back to this, the evidence base, the knowledge about the choices that are available, the options, the risks, their benefits, their consequences. And the patient or individual who knows what's important to them in making those sorts of choices. What do they want to get out of their healthcare? What are their goals? And how does that align with the options of treatment or management that are available to them? Such that a good shared decision involves a patient who's informed, has the right sort of knowledge about the options that are available. The patient knows what's important to them in that choice. We call that values elicitation, but knows what's important to them is what I prefer. And ultimately that those decisions are made that are consistent with the knowledge and values of the patient. Let me give you an example here.
I decided to have a full mastectomy because I wanted to give myself the best possible chance. So that was to get rid of all the breast tissue, which meant that if there wasn't any breast tissue there, there wasn't much of a chance that anything could grow back, and possibly also avoid radiotherapy by having the full mastectomy. And I did actually avoid radiotherapy, so that was good. And I did have those 10 days or so to think about it, and not once during that time did I waver from that decision. If I was going to be deformed, then it was a case of, well, let's be properly deformed, not do half a job. And I did think to myself that it would be so much easier to fit a prosthesis onto the flat chest wall as opposed to trying to fiddle around with bits and pieces, trying to get around half a boob type of thing. So that was, another consideration.
Okay, so there's an example of a woman who clearly, she puts it in an interesting and original way, but clearly has thought through what's important to her in a decision. And actually, there's one of the sets of nice guidelines that recognise very clearly the importance of patient involvement and engagement in decisions where there are real options, as in the case of early breast cancer. But the point is that actually preference-sensitive decisions are not rare decisions, they're very common decisions, and the more I work in this field, the more I think that there are very few decisions that aren't preference-sensitive. We talk about the obvious ones, such as the one you've just seen in the choice between breast-conserving therapy or mastectomy for early cancer, or whether to have a trial of labour after a previous caesarean section, or whether to have watchful waiting and medication or surgery for prostate disease. But actually, whether you take statins or diet or exercise to reduce your cardiovascular risk is an equally preference-sensitive set of decisions. Whether you consider diet or weight loss or medication in diabetes, these are all preference-sensitive decisions. They're made in different ways and sometimes in different forums and places, but they're all preference-sensitive. So we need to be very aware of that. This is a picture drawn in a workshop by a patient with a long-term condition, and what it effectively shows is, and very important to us in understanding this, is that over a year, that patient may have no more than 4 hours of clinical contact, which means 8,756 hours of self-management. So if we're going to get implementation of guidance in long-term conditions, we've got to recognise that that's not going to happen in all of those, just those 4 interactions, although it will need to be supported there. It's what that individual does and knows and understands and how they behave for the great majority of their life out there away from clinical interaction. And the importance of supported self-management and self-efficacy is critical in that setting. We know there's good evidence for implementation of shared decision-making supported self-management. We've just in the last couple of weeks published the latest version of the Cochrane Review of Patient Decision Aids, 115 trials in the latest version. And I won't go through all the details here, but important in improving knowledge, actively involving patients in their treatment and having patients, fewer undecided patients after the availability of decision aids and decision support for them. We also know that involving patients in their treatment choices improves adherence to medication, and that's we've already touched upon. And in supported self-management long-term care, increasing evidence that longer-term outcomes are positively influenced by the engagement of patients and individuals in their day-to-day decisions. But sometimes guidelines don't always recognise that. I think it's fair to say that you look at a number of NICE guidelines and there's strong and strengthening, I think, recognition of the importance of preferences and patient decisions here. One area we looked at recently about decision-making around implantation of implantable cardiac defibrillators, more increasingly used in patients with heart failure to prevent cardiac arrest and sudden death. But they have implications beyond the effectiveness in doing that. These are some quotes from some interviews with patients. Again, won't go through them in detail, but I don't think anything I read touched on how depressed I was going to be about it post-implantation. I was happy that I got it, but then sometimes when it would shock me, it was like, why did I get this damn thing? So there are some real implications for mental health and psychosocial implications of having one of these devices put in. And there are also some challenging things around end-of-life decisions later on. When do you perhaps turn off such a defibrillator, perhaps when another terminal illness comes along or the heart failure gets sufficiently bad? So we looked at 6 national guidelines internationally to see how they actually aligned with this issue of decision making and patient involvement. Again, don't worry about the details, but I'll pick out a couple of points. Only one of those 6 international guidelines mentioned the need to introduce the possibility of deactivation prior to implantation. Only one mentioned the need to explore patient preferences. And without exception, they reviewed, the clinical guidelines review concentrated on the benefits of the device, i.e. survival benefit, and much less so on any of the adverse effects. And when they did talk about adverse effects, it was the immediate ones like infection, rather than those longer-term psychosocial events. So sometimes guidelines may not yet be fully cognizant of the importance of decision-making and patient involvement. So how do we get guidelines and patient preferences working together? Because, as I said at the beginning, this is critical and really important as a pathway to implementation. This is a busy slide, but I want to take a moment or two on this. Both guidelines and shared decision-making patient engagement have an important part to play in the problem of variation. Guidelines are responsible for, if you like, addressing the issue of unwarranted variation. And shared decision-making is a way of supporting what we recognise as warranted variation. Let me talk you through that a little bit more. Unwarranted variation tends to occur when there's variable access to resources, to knowledge, to information, or there's insufficient research or faulty interpretation of the data, and that's knowledge-based consequences for clinicians and patients, and that's where NICE and guidelines play their role in supporting the effective implementation of the knowledge base and making it accessible to try and reduce variation where it's unwarranted. But variation will exist because there are clinical differences amongst patients, there are variable risk attitudes, variable preferences, variable willingness in patients to make trade-offs, etc. And that variation is warranted. So how do we bring those two together such that we're then, going back to where we were a few minutes ago, shared decision-making is a way of involving and engaging patients in helping to implement the evidence base. Why are patient preferences important for guidelines? Well, a few quick comments on that then. There's the ethical argument. Patients want to be involved in their decisions, so we should be involving them. The strength of the evidence will vary for important elements of any set of guidance. So some may be very strong, and there may be a highly dominant option, but in many cases that's not the case. The evidence strength varies, or even where there's firm evidence, patients will vary in their preferences, or there's more than one treatment option existing, and the choice between those treatment options is highly sensitive to what's important to the patient. And, as we've already said, patient preferences affect concordance and outcomes, so they help, if engaged properly, to create that implementation and lead to the outcomes that the guidelines are set up to deliver. And one other component here that I think is less thought through at the moment and is a challenge currently is the one about multiple conditions and multiple comorbidities that Andrew's already mentioned. One of the challenges there is how do you bring together sets of individual guidelines for a particular condition in a patient that's got several of those conditions. That's one way of thinking about it. Another way of thinking about it is that patient with those multiple conditions and multiple comorbidities is going to have to make some choices themselves. And what's important to that individual patient is likely also to influence the appropriate balance across implementation of different sets of guidelines. And I think, again, that's a really important issue that we need to think further on in terms of this challenge of multiple conditions and comorbidities and guidance. So how can we support this role of the patient and indeed the public in implementation? Shared decision-making and supported self-management both need support, and they need us as clinicians and as a system to support patients in being able to make the best of those opportunities. But there's also a role for what you might call patient push, how patients might influence their clinicians or influence the system. And we've done a fair amount of work over the last few years around implementation of shared decision making. And I want to draw a couple of examples from that of areas where we could enhance implementation through what we do and moving away from this model. First of all, accessible decision support, timely and appropriate access for clinicians and patients to the information that helps to support these decisions. NICE produces patient versions of guidelines, but I think we need to go further, and we need to think how do we ensure that both patients and clinicians have the information on risks, benefits, consequences of alternative treatments accessible at the time of their consultation, for example. And that's a benefit to clinicians as well as to patients. And one of the things that we found in the work we've been doing both here and in Cardiff in our Health Foundation Magic programme is you can produce brief decision aids that help to summarise the sort of information that supports those decisions and can be used actually within the consultation. And maybe we should be doing more of that. Don't worry about the detail of this, but here's an option grid. It's a single-page summary that compares the pros and cons, advantages and disadvantages of having an implantable cardioverter defibrillator that's been produced internationally and actually just allows in a single sheet of paper for the patient and clinician together to work through that decision. We've done similar things in the Northeast around brief decision aids, and these are now all available through patient.co.uk for patient and clinician access as well. Looking at the benefits and the risks or consequences of alternatives, here's an extract, again, don't worry about the detail, but an extract from a decision aid to support decisions about menorrhagia. We can also support patients in engaging with this by giving them support in asking the right sorts of questions. Again, from the MAGIC programme, 3 questions that patients can ask in a consultation. What are my options? What are the possible benefits and risks? And how can we make a decision together that is right for me? What's important for the patient? And how do we skill up clinicians to do this? Because this isn't necessarily easy, and it's a bit of a shift in the way that sometimes we deliver consultations to patients. And we've managed to produce some training and development programs for clinicians in supporting implementation of shared decision making. There's other stuff around supported self-management. Think of year of care and a local involvement in that. But if we want to get this component of patient interactional-led implementation working, then we've got to make sure our clinicians are skilled up to be able to do that as well. And of course, NICE itself recognises this in its own guidance and quality standards, and in the last couple of years has produced patient experience guidance and quality standards for adults in the NHS and for mental health patients, which, again, to take a few extracts from that, clearly recognise the importance of some of the elements I've been talking about, such that in a quality standard around patient experience, patients are actively involved in shared decision making and supported by healthcare professionals to make those informed choices about investigations, treatment and care, and are aware that they have the right to choose, and so on. So, and I was just reading the latest draft of the atrial fibrillation guidelines that's out for consultation at the moment, and there's good cross representation and cross-reference to this element in an area which, again, is a patient preference-sensitive area. And I'm going to do very quickly, as a last couple of things, just to set up some thinking in advance of this afternoon's workshop in this sort of wider role. So not about the individual patient and individual decisions, but the wider role of patients and the public and how that might support implementation. There are issues clearly about awareness raising and skills in the population that we're supporting. There's the role of patient representative groups who've had important roles nationally in terms of helping to develop NICE guidance and promote it, but how could we engage that more effectively across the AHSN area to help with implementation? What's the role, for example, of Health Watch in this? And these are questions that we can come back to in the workshop. Other organisations, what about the newly formed practice and commissioning PPI groups? What's their role in helping to support implementation? What about the North East and North Cumbria patient engagement experience forum that's recently been set up? And we think about organisations like HealthWorks in Newcastle and the role of people like health trainers to support implementation of public health guidance. So those are some things just for us to think about later in the workshop. And these are some questions which we'll come back to in the workshop. So how can we best do this? How can we give clinicians and patients the skills to do this? What is the role of patient experience? Okay, that's my sort of quick overview of the topic. And I look very much forward to the workshop discussions later on. So thank you.